None of the producers have any financial interest in the products or procedures shown. The Descemet's membrane, vital for vision. The neurosensory retina, also vital for vision. We know that both of these structures can get detached, leading to a decrease in vision, and both need to be reattached for functioning optimally. But the similarities extend far beyond this. Let us see how. The Descemet's membrane is the vital layer of the cornea and is responsible for maintaining corneal clarity. A detachment of this layer can occur most commonly during surgery. Just as a retinal detachment can be Rhegmatogenous retinal detachment secondary to hole, tear or dialysis, a tractional retinal detachment or serous or bullous retinal detachment, we would like to propose a classification of Descemet's detachment into Rhegmatogenous Descemet's detachment, Tractional Descemet's detachment, Bullous Descemet's detachment, and Complex Descemet's detachment. Rhegmatogenous Descemet's detachment generally occurs as an intraoperative event, causing a break in the DM with fluid accumulating in between the DM and the overlying stroma. Analogous to a Rhegmatogenous retinal detachment, Rhegmatogenous Descemet's detachment can be secondary to a hole, for example, a double anterior chamber, following perforation during deep anterior lamellar keratoplasty, or a tear. It can also occur secondary to a dialysis of the DM from its attachment at the Schwalbe's line. On the other hand, Tractional Descemet's detachment could be secondary to incarceration of the DM in an inflammatory process, for example in peripheral anterior synechiae, or secondary to incarceration in a wound or suture with subsequent contraction, as in this patient who developed Tractional Descemet's detachment following incarceration of the DM into the sutured corneal tear. It could also get incarcerated secondary to peripheral anterior synechiae within the graft-host junction. A long-standing Rhegmatogenous Descemet's detachment could also sometimes adhere to intraocular contents with secondary fibrosis, and thus develop a tractional component. Serous or bullous Descemet's detachment can rarely be seen following a posterior corneal abscess or sometimes as loculated blood. A convex bulge of the DM is seen into the anterior chamber without any break in the DM. This configuration of Descemet's membrane is also intentionally achieved as part of the Unwar's big bubble technique. It can also be seen following DMEK in an unevenly spread graft. Complex DM configurations are sometimes seen after DMEK. The graft here may be folded on itself, bunched up, or attain other complex configurations. Clinically, Rhegmatogenous Descemet's detachment is seen as an undulating membrane lying loose in the anterior chamber. It has folds and is mobile, similar to a Rhegmatogenous retinal detachment. Tractional Descemet's detachment, on the other hand, is seen stretched out tight like a trampoline between points of attachment and is not mobile. In Tractional Descemet's detachment, arc length of the cornea, if measured, is found to be more than the length of the detached DM, unlike in Rhegmatogenous Descemet's detachment, where the arc length of the overlying corneal stroma is similar to the length of the detached DM. Intraoperatively, Tractional Descemet's detachment is verified by its more immobile nature and absence of typical undulating movements seen with Rhegmatogenous Descemet's detachment on anterior chamber irrigation. Relaxing cuts performed on the Descemet's membrane help in relieving traction, and we have termed this procedure as relaxing descemetotomy. A taut DM is immobile or may show sharp, small, fluttery movements on forcible irrigation. unlike the undulations seen with Rhegmatogenous Descemet's detachment. Incisions are made in a peripheral location to avoid scarring in the visual axis. Treatment depends on classification as well as endothelial health. Both Rhegmatogenous Descemet's detachment and Tractional Descemet's detachment require internal gas tamponade and sub-Descemet's fluid drainage, analogous to internal tamponade and subretinal fluid drainage in retinal detachments. In addition, Tractional Descemet's detachment also requires relief or removal of traction via relaxing descemetotomy incisions, as described by us. These are akin to the relaxing retinotomy incisions proposed by Makema in 1979 to address periretinal traction and retinal foreshortening in conditions such as proliferative vitreoretinopathy. The decision for performing relaxing descemetotomy is further corroborated if inadequate apposition of the DM to the corneal stroma is observed on injection of air. A 26-gauge needle bent as a reverse synechiae is introduced into the AC and relaxing descemetotomy incisions are made. The number and extent of incisions is determined by assessing the degree of traction. The end point is the ability of the DM to appose well against the stroma. The incisions may be made in a can opener circumferential pattern for large area of traction, or as a few small cuts in case of a focal area of traction. Postoperative tamponade is given with air or non-expansile concentration of C3F8 or SF6. Final corneal clarity depends not only on reattachment of DM, but also on the functionality and count of endothelial cells. Complex cases might often do better with an endothelial keratoplasty. The treatment of bullous DD is based on treating the underlying cause. Surgical drainage or YAG laser descemetotomy may also be options. The relaxing descemetotomy incisions break stress forces acting on DM, relieving tautness to allow air to appose the now lax DM against the overlying corneal stroma. To conclude, it is important to recognize the different types of Descemet's detachments and the similarities between retinal and Descemet's detachment. Conventional treatment may not work for Tractional Descemet's detachment. It is important to recognize the existence of these hitherto undescribed entities and to understand the differences between them so as to facilitate proper management.